Good afternoon and welcome to UMACO TV. My name is Kemal Erkan. This is our weekly event, and this week we'll be able to discuss our clinical issues. And today's topic is irritable bowel syndrome, and we are going to discuss this in the diabetes world. Patients who have diabetes, who are dealing with diabetes, how it's affecting them, and my clinical expertise. They will join me today. So I'm going to have Joe Awley from United Medical Clinic and Donna Gunkel, our clinical integration director, and also Beth Wright is one of our dietitians. She is going to be part of this discussion. I see Joe already is there. Joe, how are you doing?
I'm great. Good afternoon. Thanks for having me today.
Well, thank you for joining us. Donna, I see you are already there as well. Thank you for joining. And just waiting for Beth. She did join, but I don't see her yet.
Yeah, I just see like a little dot.
Is she the dot? Beth, are you able to turn your camera on? Well, she'll get there. So as everyone knows this by now, so we do once a month at the 2 p.m. event, we do discuss clinical topics. And today, Joe and Beth are going to help us with that. So Joe, you should be able to share your screen. But prior to that, if you would like to, please introduce yourself. And then after that, we can start presentation.
Yeah, great. My name is Joseph Abel. I am a family medicine practitioner for United Medical. And today we are going to be talking about irritable bowel syndrome and diabetes. Let me share my screen. Fantastic. Is my screen coming through?
Yes.
Awesome. Thanks for letting me know. So today we're going to be doing a presentation with Beth, who's currently in a little bit of limbo here with Zoom, but she'll join us shortly.
Yeah, I apologize. I think she might have maybe clicked off of it. Maybe when we put her back in the waiting room. So I asked her to
She'll come back. She'll come back. So you can actually maybe message her. So then while Joe is going through his PowerPoint. And I see her joining actually right now.
All right, fantastic. Well, I'm going to go ahead and start. So to begin our conversation, today we're going to be discussing irritable bowel syndrome. It's known as many different disorders. One of the most common nicknames for it, spastic colon. And it's thought to present really in two forms. So we have irritable bowel syndrome with constipation, and we have irritable bowel syndrome with diarrhea. Now, there is one that's mixed, where you have a subset of both conditions. However, typically patients reside in one or the other. So what is this condition? Well, it's really characterized by its symptoms, and that's actually how we treat it. We have abdominal symptoms like abdominal pain, nausea, vomiting, gas, and bloating. One of the most common symptoms is bloating, and patients will usually have that abdominal pain and bloating, sometimes nausea and vomiting. And these symptoms actually will temporarily resolve after a bowel movement. So typically it's prior to a bowel movement, you're having this pain, you release a bowel movement, and then the symptoms tend to come and work their way back. But there are triggers, and treatment for both will tend to vary. It's considered a disorder of the gut-brain interaction, and there's a lot of different communication issues at play here. The gut itself can be considered its own brain, kind of the digestive system overall. So, let's break it down a little more. Like we said before, it's a GI disorder. We have our abdominal stomach pain and symptoms, and altered bowel habits or symptoms of constipation, diarrhea, bloating. But what causes it? Where is this coming from? How can I develop IBS, or how can one of my patients develop IBS? Well, we really don't know, okay? There's not a clear etiology. It's thought to be a disorder of muscular contractions and an impairment in them, and dysfunction and dysregulation of them, and the gut of the microbiome and the GI tract overall. But there are triggers, we know that, and so we can control them. And some of the main ones are stress, emotional complications, foods, after and status post-bacterial infections, parasitic infections, and even diabetes. It's a major trigger for IBS. And so that brings us to the main question of this topic. And it's, wait a second, my diabetes can have an impact on my IBS? And the answer is yes to that question. They play hand in hand. I actually call them partners in crime. So let's just break down some stats here. 10 to 15% of US population has this condition, either subset, constipation, diarrhea, or mixed. It typically presents in a 2-to-1 ratio. Women are more likely to get the condition. Again, this is not really known why. It's just population statistics. Most symptoms are going to start before age 40. However, we can see a late onset of this condition. So, when we're talking about treatment, how do we treat it? I mean, there's 2 different subsets of treatment. That's non-pharmacologic. So we're not dealing with the pharmacy. This is just natural treatment. And there's pharmacologic. And first, for the non-pharmacologic, we got to find the trigger. And so I encourage all my patients, and, and I'm sure you do the same thing in this regard, to food journal. It's very important to food journal, symptom journal. Make yourself aware of what foods you're taking in, what symptoms you're getting after those foods, what setting and environment you're in, and how you could be feeling as it relates to stress, anxiety, psychosocial stress, that are also all triggers of IBS, and less FODMAPs. And we'll get into that a little later as well. Those are subsets of foods that are also triggers for this condition. You want to manage your stress. Psychosocial management is huge. Stress and anxiety are 2 of the biggest players in IBS and IBS exacerbations. And so I often refer a lot of my IBS patients to therapy because of it, because there might be undiagnosed depression or anxiety. The patient may say, well, I have been depressed or a little anxious, and I have been having thoughts and possible, lack of motivation, interest, anxious baselines. And so it's important to realize the 2 are so heavily related. And so I refer a lot of my IBS patients to therapy, psychiatric doctors, and treat them in that regard, and make sure to screen them as well for depression and anxiety. You want to do some more lifestyle changes as well. Diet and exercise are key. Exercises like walking, yoga, swimming, all mindfulness exercises, meditation's fantastic as well. Anything that'll really promote well-being will also promote good digestion. So when we get into the pharmacologic, we have a bunch of different treatments. And like I mentioned previously, we depend our treatment based on our symptoms. So if we're constipation dominant for our IBS, we start typically with Miralax first line, and then we'll do some hycosamine, maybe dicyclamine, which are antispasmodics, which are going to help with pain, peppermint oil included. If we get a little further, it gets a little worse, we tend to think about some secretory medications like Linzess, which is the one highlighted there, linaclotide, which is a great medication as well, one that I have great success with patients. And now we're flipping the coin here to the diarrhea dominant side. We see one that's very common, Imodium. I'm sure many people watching this presentation use Imodium, and that's an anti-diarrheal medication. Prevents diarrhea, prevents bowel movements, slows down the kind of muscular contracture of the intestines. Now, we're also using the same antispasmodics as constipation dominant. And why is that? How can we use, one for both? Well, with these antispasmodics, we're really treating the pain, okay? And the pain that comes along with muscular contraction, dysfunction of the GI tract. Okay, we can also use an antibiotic. We can use amitriptyline, which will help with mental health. We can use elocitron, which is also, beneficial for nausea, and another medication called cholestyramine. And these medications typically we use as the disease itself progresses. So this is a really, involved picture on IBS. Basically, what I want you to take from this picture is that it is a brain-gut dysregulation. The brain and the gut are in constant communication. When one is off, the other most likely is going to be off. So we see our risk factors here, our triggers for IBS, that's anxiety, stress, depression, any psychosocial issues. They can have an effect on the hormones, peptides, proteins, cytokines, all these little guys that play into our musculature dysfunction of the intestine. And it goes the other way as well. If we're having dysfunction of the intestine, diarrhea, constipation, we're also going to have dysregulation in the brain as well. And, many people don't like to have discomfort in their stomach. I don't know one person that does. And so it's going to affect how you think and how you go about your day. And it could have an impact on your, activities of daily living. So, we brought up this link to diabetes. How are they linked? Well, the first thing I want to, bring up again is you want to think about the gut-brain interaction. So diabetes can damage the nerves, and there's nerves in your gut which control the muscular contraction. And so that can disrupt that communication we've been talking about. It disrupts the routes that, both hormones and both nerve function pathways can go and innervate each other. You want to think about plus sugar, excess sugar. And that's typical with diabetic patients. Think about diabetes, a disorder of insulin from the pancreas and peripheral sensitivity to insulin and glucose and sugar. And now sugar kind of resides in the body longer, typically with patients with diabetes. This can cause inflammation. Inflammation in return can cause increase in permeability of the gut. So more things are crossing through the gut line. Okay. It's also going to damage the nerves. Okay. When the nerves of the gut are damaged, the innervation and intervention are going to be damaged as well. And you want to think diet. Many of the foods that cause diabetes can exacerbate gut function or make it worse, or make it more likely that we're going to have some dysfunction of the gut and the muscular contractions. Those are your artificial sweeteners, your sugars, your processed and manufactured foods, foods high in FODMAPs, which we'll get into. So this is a good figure of diabetic peripheral neuropathy, nothing to do with the GI tract. Basically, this picture, I want you to see how it affects the nerves. And so here we can see the nerves in yellow here and strands of nerves that kind of extend out in 3D towards you. You can see a healthy one here on the left side, healthy nerves, good blood vessels, the muscle is innervated, it's nice and pink, it looks fantastic. And now when you switch to the right, when you have excess sugar and uncontrolled diabetes, that sugar is going to damage the nerves. The nerves are not going to conduct as well. The intervention is not going to be as good. The musculature is going to, fall victim to this. And so is the communication between the gut-brain axis. And this can promote our IBS. The same thing is actually common with bacterial infections that can damage the GI tract as well. That's another trigger of IBS, but diabetes specifically can damage these nerves. This is a very involved picture of the GI tract itself. All I want you to look at are these yellow lines that come across the muscle of the GI tract. These are the same nerves we've been discussing. With excess sugar, these nerves are affected. They're broken down. They don't look as good as the prior healthy nerve, as we can see here on the right side. And so what happens is this musculature, the submucosa, is affected, and the integration, the movement of the bowels is affected overall, promoting IBS. So they're partners in crime. They work together in a sense. High blood sugar is going to lessen the speed of digestion. It's going to create those symptoms that are very common of IBS: bloating, abdominal fullness, nausea, vomiting, abdominal pain. For diabetic patients with uncontrolled A1Cs, fructosamines, fasting glucoses, sugars lasting longer in the body, causes that inflammation we talked about. It's no good. What happens is the damage to these nerves is going to cause altered bowel habits, promote IBS, and promote malabsorption. So down the line, it can lead to malabsorptive disorders. And this also causes alterations in the gut microbiome. I'm sure you've heard this phrase before. What is the gut microbiome? We have a lot of microbes in our gut, specifically our colon. Most of them consist of bacteria. These bacteria actually outnumber the amount of cells we have in our own body. It's pretty fascinating. There's a lot of research being conducted today on it. And what happens is the microbiome works in symbiosis with our body, which means it works together. It works to help us. And so the gut microbiome can stimulate our immune system. It can synthesize hormones and vitamins, and it can break down toxic food compounds that we could have digested. And so it's important that we keep our gut microbiome healthy. And that brings up a separate aspect of this presentation, which we can spend a day on together. And that's the role of probiotics in IBS. And now the research is hit or miss. There's positive research out there that says probiotics will help IBS. And there's some that says it doesn't really do much. Probiotics, for those out there who don't understand what they are, beneficial gut bacteria. Okay, so you're replenishing the gut microbiome with healthy probiotics. There's tons of different strands of them. We use different strands for different diagnoses as well. And so the research is hit or miss on it. I typically like it myself. And I know that when many of my IBS patients try it, they find success with it. So you want to make your diet changes. You want to eat more nuts, seeds, beans, foods high in fiber as well. High fiber is going to promote healthy digestion, promote bowel movements, relieve pain from IBS. You want to increase your diet in fruits. You want to stay away from dairy for the most part. And you want to increase your diet in meat and fish like chicken. You want to stay away from those artificial sweeteners, especially potent in our diet sodas and our sodas. They lead to a lot of abdominal gas and bloating. Now, these sodas also contain carbonation. This carbonation, this CO2, is also going to promote IBS symptoms, okay? And so we want to stay away from these processed foods and limit our sweets overall as well. This is a diagram on FODMAPs, and we'll get more into it as the presentation goes along. FODMAPs, certain molecules, fructans, galactans, lactose, fructose, mannitol, sorbitol. All you need to know is there are different subsets of sugars that consist in different foods that can really act as, really severe exacerbating triggers for IBS. That's legumes, dairy products, your apples, pears, pitted fruits, mushrooms, cauliflower. And so I tell a lot of my IBS patients, hey, take a look at this chart, rely on it, keep it in your phone, keep it in your background if you really have severe IBS, and try and base your diet on it. And if you do ingest one of these foods, try and food journal at that point. Take home message. You want to seek medical intervention through the provider and the dietitian. Specifically, as providers, what we can do is we can diagnose your IBS, help treat your IBS, and help work on finding triggers with your IBS and treat them accordingly. Whether it's diabetes, stress, anxiety, depression, we can help you through this process. You want to keep a good food journal of what you're eating, what symptoms you're getting from these foods, how they're complicating your life and your symptoms. Good sugar control is going to be good IBS control. Sugar does a lot of damage on the body and those nerves of the gut. Good IBS control comes with that psychological aspect. So let's do a good job of managing stress, anxiety, and depression. That's going to help with our IBS. Think the gut and brain communication. They're always talking. They're best friends. Exercise is key, promotes blood flow throughout the body. And you really, like I said before, we want to manage our chronic conditions to provide effective treatment for IBS and diabetes. And that is my presentation. I thank you guys for listening.
Joe, thank you. This was very, very useful. So one of the things that I want to point out and wanted to get your opinion, as you know, many of the people, and Beth, feel free to also put your opinion out there as well.
Okay.
So one of the as I'm listening to you, one thing that comes to my mind is as we are trying to kind of make certain things regular in our body. And this is with the bowel, right? So like there has to be some kind of like some schedule almost. So if we eat constantly, every 2 hours we are eating something, then our body is working for the entire day nonstop. Therefore, everything else is going to work nonstop. More than necessary, right? So, I mean, personally, I see a benefit of like intermittent fasting, where it kind of regulates when to actually go to the bathroom. So then the body learns certain things, and then I'm just speaking from the personal standpoint. And then I see some people who are struggling, who are constantly eating some junk food, something else. Like the body doesn't stop. And then with our Bariatric Friday event, Dr. Erkan and I, we discuss this all the time, and intermittent fasting is one of the tools that we use for the process, but benefits of, how we can regulate certain things in our body. I think fasting has some advantages for those people who may actually struggle with the with understanding. I think the fasting could be a good start. And they don't have to do it every day. They don't have to do it, 20 hours. They can always start with some like the 12 or 14 or 16 hour periods. And like today I did it for 16 hours. So, and, I think because this is a healthcare presentation, and to make it more relatable, all four of us on this call, and then Sean his camera is off, but he's here. All five of us, we have from different ages, different genders. We have different types of these issues in our lives. So the only way, you know, patients probably need to bring this to our attention. One is timely, because sometimes we are embarrassed to talk about certain things, especially if it's about the bottom part of our body, including myself. So there are things that I didn't discuss with my PC, but I talked to my other primary care physicians who are friends. So, because sometimes it's just a comfort issue, right? But the problem is, if you don't have friends who are primary care physician, you have to talk to your primary care physician. So the timing of it is important, because once it's too late, then it's going to be more difficult to take that in control. But I do want to point out, and tell me what you think. This fasting is a good way to start the regulation in the body.
It's a great way. I mean, there's a lot of research done on the 16 and 8 fasting, you know, where you're only eating from 12 to 8. And that is a window of opportunity for the body, because the body realizes, hey, this window is when I'm going to digest. It's when I'm going to produce all my hormones and get everything out of the way that I need to. And it helps with the regulation of digestion. When you're snacking consistently, your body and your pancreas specifically are releasing a lot of hormones, insulin, and a lot of secretory enzymes from the pancreas that are going to affect the way we digest. And it's going to be just too consistent for the body, especially if you're taking in sugars. People don't realize when you're taking in sugars, you're drinking all that sugar. And so your body has to break it down, and it's consistent. And so if we can keep a window, you know, like the 16 and 8 fasting, there's been very positive research on it.
Yeah.
And then I would just jump in to play a slight bit of devil's advocate, although I agree with both what the two of you have said. There's research out there that shows that this can be an incredibly effective method for a lot of people to help with dysregulated eating patterns, and also agreed with hormonal balance, etc. But sometimes it isn't. Obviously, there's nothing we can make the same for every single person. And so we do find it doesn't work for some people very well, in that if you fast for so long that it kind of sets you to overeat, then that can be too demanding on the system when you do start to eat. And in that case, we have to kind of person by person determine what fits best with that individual. And then there is some benefit, I would say, to not going so long during the day. We tend to say as dietitians, try to eat something every 3 to 4 hours of the day in order to keep your metabolism working, but definitely what you eat and how much you eat is important. So I think both of these approaches have validity, and it really does just take the process of working with your healthcare people to see what works best for you.
No, absolutely. And I'm not discounting any of those. And the other thing that these are different types of tools, and some works better with some people and some doesn't.
Absolutely.
So I find fasting a lot easier. When we say fasting, I just want to make sure that we point out, drinking enough water is the key. And that you have to keep your body hydrated. So, but it's not, as you said, it's not going to work for everyone altogether, but most of the people do benefit from it. And also, there's this logical, sense where I know that there is a schedule in the body, and each organ has to do certain things when we do X, Y, Z, and this communication between the gut and the brain is so strong, and then there's so much going between the two. So if we are able to help the understanding of that, and then have some set schedule of how the body should be functioning, I think we may be in kind of better control of what we are doing. That was where I was coming from. Now, but I know we have the IBS issue from the nutritionist standpoint, and I know you are going to cover that for us.
I'm hitting share screen, but it says it's disabled.
No, you should be able to do it right now.
Okay, let me try it.
I think it was earlier. Yeah.
Yes. Okay, good. So let me see if this works.
Yes.
Okay, good. And now let me try to get full page here. Bear with me. No.
So you want to open that as a download, I believe. I can see the top part of that.
Let's see, sorry.
If you can download that PowerPoint, so you are in the team, you probably want to download that would be nice.
Let me get out of that. I thought I had, but let me try that again.
Okay, you want to minimize the team maybe?
Sure.
I think you are just sharing the team. That may be the problem. You need to like maybe stop sharing and restart by choosing the screen.
Okay. So let me do that. I'm going to make that smaller.
We have a lot of technical issues, not just for today, every time. So it's kind of like, it's a norm. So now I'm going to stop sharing it for you so that you can.
Okay, that'd be great.
Let's restart and then see if you are able to see the PowerPoint itself.
That'd be great. Thank you.
Go ahead.
Okay. I don't think that's going to work. Let me try it from. Okay. What I can do is I can go onto my PowerPoint and I just might skip a few slides. I think that might work.
If Joe doesn't mind, just maybe something from where we left, Joe, from your side.
It cut out. What was that?
Is Joe able to just continue with the PowerPoint?
I could do that. Yeah.
That'd be
Share my
great.
screen.
Okay.
Sure.
And then let me see if I can advance from there. Okay. Doesn't look like I can advance, so I might just say advance slide. How about that?
Sounds good. Sounds good. You let me know.
Okay. Go ahead and advance the slide. There we go. All right, thanks. And I'll just let you know. I appreciate that. Sorry about that. All righty, so taking off from where Joseph started, and he gave a huge amount of very important information. When I'm just talking about this subject myself, I often highlight a lot of the information and facts that he talked about. So I'm going to try to talk about some different aspects of things. One of the things, though, that I think I'd like to start off with is by perhaps clearing up a little bit of confusion, because sometimes when I'm talking with my patients about IBS, which is our subject for today, irritable bowel syndrome, they sometimes say, well, wait a minute, I thought maybe it was IBD. What is that? And so there is something called irritable bowel disease, but that is different than what we're talking about today. The irritable bowel disease might be things like a Crohn's diagnosis or colitis diagnosis, and those tend to involve changes in the actual health of the GI tract and is often diagnosed with an endoscopy. With IBS, as Joseph pointed out, it is more of a functional disorder. So you don't necessarily have major issues with the tissues, et cetera, in the GI tract, although nerves and things can start to be less healthy and start to cause some issues, for example, as in with the diabetes. Anyway, so talking about IBS, it's important to be in communication with your healthcare team, your primary care, perhaps a GI specialist and a dietitian, to let them know what's going on so that they can go ahead and rule out perhaps IBD, so then you can receive a diagnosis perhaps of IBS. Go ahead and jump to the next slide. So where the dietitian definitely comes into play when we are trying to help people address this issue through what they're eating that could be triggering a lot of the symptoms that impair their quality of life. So the goal here is to identify what food triggers the worst of the symptoms, and then eliminate those, but eventually broaden the scope of what you eat so that over time you are not avoiding entire categories of food, because what that over restriction can cause is eventual nutrient deficiencies. So we want to find the sweet spot where we identify the few things that make you feel miserable, monitor those, but let you eat a lot of other healthy things. And it's interesting, this FODMAP approach really is fairly new in healthcare. It was really taking hold in the early 2000s, around 2006 is when it was introduced as a possible treatment for IBS. Go ahead and jump to the next slide. Alrighty, so let's figure out, we throw around this acronym FODMAP, but let's talk about what does it mean. So the F, meaning it refers to fermentable. How are these sugars broken down? And we're going to go more into that in a second, but go ahead and advance to the next slide, please. Alrighty, so the O refers to oligosaccharides. And so again, and I think Joseph mentioned that these FODMAPs are carbohydrates, or otherwise known as sugars, but there's different kinds of molecular structures of sugars, and they affect our GI system in different ways. And sometimes some of us are more susceptible to some categories of it, but not others. And that's what this FODMAP process is about, is to identify what my patient's body might be more susceptible to. So the oligosaccharides are your longer chain sugars. They're like 3 to 10 molecules in length, and they're found in more predominantly in certain types of foods, as you can see from the lists there. Your disaccharides are the D in FODMAP, refers to your 2 molecule chain sugars. Commonly, there are 3 that we're most familiar with. So that would be sucrose, think table sugar. The second one would be lactose. So, for example, milk and various milk products tend to be higher in that disaccharide. And then something called maltose, which we're a little less familiar with, but oftentimes there's maltose included in cereals and candies, etc. You can jump to the next slide, please. All right, so let's continue with figuring out this FODMAP acronym. So the M we've just talked about, the A, and then the last one being your polyols. And polyols basically refer to, well, we didn't actually talk about the monosaccharides. I'm sorry, let me jump back. Monosaccharides, 1 molecule, that is the simplest sugar. You can't break it down further. So the 3 monosaccharides would be called fructose, glucose, and galactose. All right. Now we're going to talk about polyols. So the polyols are found naturally in a lot of different foods, particularly certain fruits, certain vegetables. They're particularly high in mushrooms, for example. We also then have a category, the polyols, that we refer to as sugar alcohols. And sugar alcohols, basically, that is it's a derivation of sugar, and we use those in certain food products like sodas and candies, sugar-free candies and things, to give us a sweet taste, but we do not fully absorb those, and they pass through our intestines unabsorbed. But those can trigger some GI symptoms worse in some people. So some people might have to really work on eliminating that particular category of food from their diet. Go ahead and jump to the next. Thank you. So this slide is a similar slide to the one that Joseph had in his presentation. What I like to point out here is that some foods or categories of foods don't fall into just one of the FODMAP sugars. It might be in a number of them. So for example, if you look at this list, you've got apples and pears, both in the fructose and in the polyols category. So sometimes it could be a combination of the FODMAPs that is triggering one's symptoms. Go ahead and jump forward. All right, so this is my favorite slide. So this talks about what the dietitian would do. And it's actually a pretty involved process, but research has shown, since this has really started to be used since the early 2000s, that about 3/4 of patients that go through this approach find some significant improvement in quality of life and lessening of these IBS symptoms, albeit about 1/4 of patients don't tend to respond well to this process, but significant majority do. So it's usually worthwhile going through to see if it will help. So it's broken down, as you can see, into 3 phases. Phase 1 is it's the most restrictive stage. So what the dietitian does is they give that our patients guidance on how do we get rid of almost all FODMAPs in your diet for a short period of time. This is usually somewhere between 2 and 6 weeks. So this is not just the polyols or the fructose, it's all of them together. So your variety of what you eat is pretty restricted for a while. So we do want to get out of this and start the second phase as soon as we can, because again, we don't want to start to develop nutrient deficiencies in the long run. And also, it's no fun eating just a tiny subset of foods that we like. So the goal here, though, is to basically rid you of your symptoms, let your system, all the inflammation that can occur during IBS flares to settle and to basically kind of heal up a little bit. And then we jump to phase 2. Phase 2 is your reintroduction phase. And over a period of 1.5 to 2 months, you work with the dietitian. And this is where the food journaling that Joseph referred to really comes into play. So what we will do is we will pick representative foods from each of those FODMAP groups. And we will have a patient try a very small amount, and they usually measure it out. And then they journal, how do they feel after this, after a few hours, after that day? Do they have any symptoms? And they might write down no symptoms whatsoever at 1/4 cup. So if they don't have any symptoms from that item, then we'll say, okay, so the next day, try a 1/2 cup. Do you have any symptoms? Maybe at a 1/2 cup, they did have symptoms. How bad were the symptoms? Were they just mild and you were like, I had something, but it was okay, or excruciating? Well, now we've got a bit of a roadmap here. So we can indicate at what point could we handle the food, if we could handle it at all. Anyway, and we do that for each of those FODMAPs. So we are building, and now let's refer to phase 3, your own personalized diet. So that, again, the goal is to expand, again, your access to all kinds of healthy foods, and then have identified which foods you don't tolerate at all, or what foods do you tolerate at smaller amounts, but not larger amounts. So in this way, you might have, let's use that apple example. If you didn't react to a 1/2 an apple, but you reacted to a whole apple, well, maybe you can include apples in your life. You just know to always keep it to a 1/2. So that, in a nutshell, is what the dietitians do in this approach. I would recommend, if this is something that you're doing, that you want to seek out a dietitian that has specialized training in FODMAPs, because it is a pretty complex process, and you don't want to necessarily just kind of do it willy-nilly. There was one more slide, if possible, but if we can't get to it, that's fine.
I think I just stopped the sharing for Joe.
Okay. No,
sorry.
That's all right. No worries. I can actually just really quickly talk it through. It was basically pointing out that although this diet does tend to help a lot of people, up to 3/4 of the people that have these symptoms, to really improve their quality of life, it is not the only thing. So for that quarter subset, as Joseph mentioned, there's the pharmacotherapy that probably needs to happen. There's also psychological therapies that we are finding that research has really found some benefits to, doing some cognitive behavioral therapy, doing some mind-body connection. And I know, Joseph, you referred to some of that earlier because of that gut-brain access. Lifestyle change, all healthcare professionals talk about exercise. I mean, there's really hardly anything exercise doesn't help. And yes, this also helps. It helps with gut motility. There's also other dietary things that we can address if the FODMAP diet didn't work. And sometimes it's just like reducing caffeine consumption, reducing fat consumption, reducing alcohol consumption, reducing spicy foods, and, as Joseph referred to earlier, increasing fibrous foods. Those things can sometimes help with improving quality of life. And then there's also interesting new research being done on specific work in biofeedback. And that can help people. There are therapists now that are actually specially trained in biofeedback for gut disorders. And they work on specific relaxation exercises that can help you fine-tune certain body functions. It's fascinating. And then, yes, there's the probiotics and herbals, and correct dietitians. We read a lot of the science as well. And yeah, I have patients ask me about that. I'm like, it might help, it might not help. I don't see it as a bad thing. So I usually do say, let's try some, give it. It usually takes a couple of, like about 4 weeks to start to see if it's going to help or not. Is that your experience, Joseph?
On the same timeline, yeah, I keep them on it for 4 to 6 weeks, and then I follow up with them.
There you go. Exactly. So if it's not helping after about 6 weeks, maybe you need to try a different strain, but it's not necessarily you should keep spending the money on some expensive things if it's not really helping. Yeah. So anyway, there you go. That's my take on things.
I think the best is what I was saying earlier, like for timely, looking for the help in a timely manner, so that don't wait. So go to your primary care, discuss the issue with your primary care, and he or she can initiate other specialties as needed, but certain tests needs to be done. But earlier we are able to diagnose these issues, it's easier to manage. And also, look for other resources, tools to help the situation, educating yourself with these. I mean, if you have time left after today, after this discussion, we'll discuss AI in medicine, how we utilize. There are a lot of tools available out there to better understand our body. And that's, I believe, where we can actually help our own situation with the help of our primary care providers. So I do thank both of you joining and presenting. And I know this is a great resource for our patients, for them to be able to listen to some of these, and just adding more out there for them to be able to hear these things from different sources. So I do believe that we are helping them a lot. And thank you for joining us again. Donna, thank you. And then Sean, I believe, is going to join me, and we'll discuss the AI in medicine. And I'll see you guys later.
Thank you. Take care.
Nice to meet you, Joseph.
Nice to meet you too. Have a good one.
Bye.
All right. Sean, what did you learn from this prior presentation?
I learned that Joe and Beth are very well educated on the subject. Plenty of information there. Easily rewatch that 2 or 3 times and still be learning new things.
Right, there are a lot of information.
Very in depth, yeah.
Yeah. So, I do believe that these are, again, helping a lot. So, because as we listen some of these things, we don't necessarily learn and understand everything at the first time. So this will be out there and then will be available after the live event. So we can start the discussion on the AI in medicine, but I know we're not going to have enough time because we have Bariatric Friday at 3 p.m. Dr. Gail Wynn is going to join us. So, but let's start the at least the discussion of it, so that we can probably continue next week.
Yeah, definitely. So as you mentioned, AI, artificial intelligence, is kind of a big. We've seen a big push in it in the field in its entirety recently, across various realms, but the fact of it being involved in healthcare now, we're starting to see that kind of surface up. If you're thinking about even just the Neuralink, how we mentioned that months ago with Elon Musk and how it's going to be the artificial intelligence, but it is also included in various other aspects across healthcare, and it's something we're also going to keep following. We do want to have a little introduction here today. Thinking healthcare with artificial intelligence. Some people think of even like the robotic surgeries, how that's the technology involved with that. The laparoscopic surgery, how you're also doing that with minimally invasive. So the scars, I think, are like the size of like a pinky nail.
So the robotic versus laparoscopic. So laparoscopic is the one that we are doing already, and the robotic also we are doing, but not for every case. It's
it's less more selective. So we just wanted to kind of introduce the topic here, and I know it's going to be something that's going to be changing, obviously, in the future for months, years to come. But just the fact that it's surfacing, becoming more popular now.
So I guess like some of them we already start using without realizing, right? So there's so many things out there available, including the chat boxes, the chat GBT. There's the robotics has been used for decades now. The research studies how it's speeds up the process in some cases. So, but there are some ups and downs. And just like the way that we start discussing the Neuralink, as you correctly said, that was almost 2 years ago when we started, and now it's getting to somewhere. So some people are going to benefit from these, and the regulation is going to be important. But this is a really important topic for us to kind of spend enough time. So what I was saying earlier, how people can actually help their situation, better understand their body, and better manage certain things. There are, AI can actually help and is already helping in some ways.
Right.
Whether or not we are utilizing it properly is the key. So what Anthony was presenting last night in the providers meeting with this the belt. So I can see some benefits, but I see I don't know if how much I see some benefits, but not a lot. But there are certain ones that's definitely helpful.
Even that belt example, things like even your Apple Watch, like a Fitbit, that already helps like that healthcare where it's happening without you actually having to spend your focused time, where it's just keeping track as you go about your day without you even knowing. But also in another sense, I think when people think AI, they're thinking the actual procedure being done on a person, whether it's surgery or some type of exam. But even just also in healthcare, think about the automated text systems that you have sent out, where it can decipher what a person's responding back. If they're confirming their appointment, it'll know what to respond back. Here's the address. If you respond to Y versus the N, it'll say yes, you're confirmed. So it's not just on the patient in the exam room versus there's so many other fields that the whole process, each step of the way, that can be.
Well, right now, many of the grocery stores that I don't go to those places much. So I was there last Tuesday night at Wegmans, and you have to do your own checkout. So that's right. So it's not in healthcare, but it's just how it's in our life. Did I enjoy that a lot? No, but it's not like we are given an option, and I think that's what's going to happen in healthcare. So there are certain things already in place, and maybe next week we can kind of. I want you to kind of think about this. So should we actually kind of put everything under AI? Because there are certain things that are not at the level of, like when you say AI, like I'm talking about like ChatGPT, right? So ChatGPT is, everyone is using it, right, wrong, different, but it gives you certain things in a really meaningful way. So in my opinion, some things that we call AI related today, they're not, they're just like some computers system. But I think when I say AI, I'm really talking about something at a higher level.
Yeah.
Something that can process, make decisions, and be in charge of a plan of action rather than just, answering a chat message.
Automated versus the actual thinking process. Because like as you're saying, maybe there'd be one physician who will oversee 4 AI ones where it's taken an algorithm of if a patient is saying these are all the symptoms, it's going to then think and say, all right, here's what they should be prescribed. This should be their plan of action.
Yes,
Like
and it would be trusted. So I think maybe we can leave it here for introduction, and then we'll pick it up from here next week. I think it's fascinating in a way that we so many things are there available and will be available, and how we are going to incorporate those and utilize those in our lives is going to be pretty interesting. So we'll be back with that next week. So in a couple of minutes, we are going to have our Bariatric Friday support group aspect that's going to be with Dr. Wynn. So we'll be back in a couple of minutes.